Hello viewers, I am Dr. Ramesh Gajula, endoscopic spine orthopedic surgeon. With me Dr. 𝗣𝗡𝗘𝗣, she is an interventional pain physician. So we are going to show you how to perform a fluoro-guided cervical epidural injection. So ultimately, what are the things required? What is the fluoroanatomy? What's the normal anatomy? What are the side effects or untoward things can happen if you are not so meticulous with the procedure? That's what we are going to discuss in this video. See the positioning of the patient 100%. This procedure requires a consent from the patient, that's mandatory, and proper ASA monitoring. If you see there, the monitor is tickling there, the monitor should be there, and the patient is connected to a oxygen. We have put almost 2 liters of oxygen, and if you see the position and all the drugs which are required for resuscitation, you should have definitely a defibrillator with you. You should have all the drugs required for the standard as far as ASA guidelines are concerned, all the drugs, because patient can go into allergic reactions, patient can go into vasovagal reactions, anything. We should be ready to tackle that situation. So it's mandatory to have every gadget. That's number one point. If you look at the position, see the patient is conscious. Nana, beta? Yeah. And if you see, we have put a pillow under the chest. See here, there is a pillow under the chest so that the neck is flexed. The reason why we are doing is, number one, to make the interlaminar window little wide open, that's number one, and number two is to make the space available between the ligamentum flavum and dura more, so that there is no inadvertent dural puncture. So that's the reason neck flexion is mandatory. This is a position adopted. This is mandatory. What are the things required for this procedure? Number one, if in case if you are anything anywhere in the world, any part of the world, if you are injecting with any needle which is larger, wider bore than 26 gauge, you require to give a local anesthetic. Normally we use this 26 gauge needle. If you are not meticulous in the procedural technique, please don't do cervical epidural injection unless until you are very good at doing lumbar epidurals. If you have done more than 100, 200 lumbar epidurals, then only venture into cervical epidural injections. The reason behind is, when you are injecting with the help of Tojis needle, if in case if you counter an epidural vessel, then there is a probability of hematoma in the epidural space that can cause compressive effect on the spinal cord. That's number one. Number two, your drug can get into the epidural space. From there it can even get, if in case if you do a independent epidural vessel puncture, then the drug can get into a blood vessel leading to toxic reactions. That's number two. Number three, if there is a possibility of dural puncture, patient can have post-procedural headache. Number three, if not only dura, you have injected into subdural space, then there is something called as a compressive effect on the spinal cord. So you can come across all the symptoms related to compression of the spinal cord. Patient can have sudden onset of motor as well as sensory blockade. Ultimately, cardiorespiratory arrest and death can happen. And number three is, if there is inadvertent subarachnoid, like you are injected into subarachnoid space, then also patient can land in sudden sensory motor block along with cardiorespiratory arrest and death. In case suddenly we have put unknowingly the needle into the spinal cord and unknowingly you have injected the fluid, then there comes a possibility of syrinx formation that can land up in quadriplegia and death. So all these complications are there with this procedure if you are not meticulous, but to be frank, if you see the old literature, hardly it is 0.5 to 1%, nothing to panic. And along with that, there is a possibility of allergic reactions to the drug, and vasovagal shock is also possibility. If you are not sterile in your draping, yes, it can lead to epidural abscess also. So that's why this procedure requires meticulous, and you should be well versed with the procedure, otherwise don't venture into doing a cervical epidural injections. So this is all about the untoward things about cervical epidural injections. Thank you. That's one thing. And the second is, the main purpose is you want to push the spinal cord more anterior so that there is a space between the ligamentum flavum and the thecal sac. In case you are not smart enough to appreciate ligamentum flavum, you try to push it more beyond LOR, still there is no chance of any inadvertent dural puncture. You are getting my point? So that's the reason you put a pillow under the chest. Already we have inserted the Tojis needle into the epidural space. We have double confirmed with LOR to saline as well as 𝗖𝗘𝗡𝗘𝗣 non-ionic contrast dye. Now patient is conscious under ASA monitoring, oxygen there, pulse oxy there, we are with all resuscitation kits. Now I am injecting normal saline. This is to flush away all the inflammatory mediators there in the epidural space because of, now in this case it is because of the disc herniation. So we are going to flush. This is a normal saline. This is preservative free normal saline. You see, already aspirated. Now aspiration done. Aspiration is to confirm that the needle has moved, not moved into the epidural vessels. Okay, now I am pushing ml by ml. I am flushing all the inflammatory mediators from the epidural space. I am nicely flushing with 5 to 6 ml of normal saline. I have done it. Now we are going to give the drug, which is so easily going. This is 0.2% bupivacaine and 8 milligrams of dexamethasone. If this is a chronic case, you are suspecting in the dye spread, if there are any flimsy adhesions, you can add hyaluronidase 1 in 1500 units to this, so that it is something like a neuroplasty. Okay. Otherwise, you can put an epidural catheter inside to admit the patient. You can use an hypertonic saline also for the sake of neuroplasty. So now this case, we added 0.2% ropine with dexamethasone. I think they have even added hyaluronidase. This is a chronic case, it seems. Now we are going to give the drug. In the medication, what we are doing is, the cervical epidural space is a limited volume space. So we have given huge volume. So in old days, the intervertebral foramen is almost, the dimensions are closed. So in order to move the drug out of the foramen, I am trying to open up the intervertebral foramina by doing lateral flexion of the neck. Patient is conscious. Immediately of the procedure, you are not supposed to send the patient home. You have to keep the patient at your facility at least for 1 hour to see any untoward effects of your drug, of the procedure, or any kind of such kind. Okay, and you have to give your personal number to monitor the patient for next 1 day. Okay, see here, this is a dye spread pattern in cervical epidural injections. In AP, you are mandated to see not only the contralateral oblique view but also in AP view. You see here two things which you should appreciate. These fat globules which are unstained by the your iopic non-contrast dye, that indicates that you are in the epidural space. That's number 1 point. Number 2 is the dye is coming out of the, this is a pedicle here, it's coming out of the pedicle. It means that you are in the epidural space. Because these fat globules you can also see between the lamina and your erector spinae, the back muscles. So there is always a probability. That's why it is mandatory that the dye should come out. But initially when you give the dye, only 0.1 or 0.2 ml to see the proper spread. Then whatever the remaining quantity you want to, if you want to see whether it is coming out of the foramina or not, you have to give some more volume, either 1 or 2 cc. As I told you, you can use a continuous real-time fluoro as a beginner, or you can use, even the present guidelines says that if you want to avoid radiation, you can use intermittent shoots, but wait for 6 to 8 seconds and then you can see the dye spread. Whether the dye has disappeared, it is still there, whether it is intrathecal, subdural, epidural, or in the musculature. Thank you. So, whenever you are inserting the needle, you should never get confused between the end plate and upper border of the lamina. Can someone give me cervical model, please? It is there, Dr. Saab. If you look at here, see, we are trying to attempt at C7, D1 or D1, D2 or 6 and 7. So, our area of interest is always upper border of the lamina. So, that once we hit here, we are almost in a coaxial view. So, our X-ray beam makes this tip and the hub in one plane. It appears like a small dot. That is nothing but end-on view or tunnel vision or whatever. So, once you hit here, you are slipping. That is the actual technique or technique. But what happens sometimes if you dock here, if you want to slip, sometimes what happens, it will go and hit the lower border of upper lamina. So, there is a lot of difficulty because the interlaminar window in cervical is not big. Always remember, in order to make it big, I already told you, you are supposed to put a pillow under the chest so that the neck is flexed. There are two added advantages. One is this. The other added advantage is the spinal cord is pushed little anterior from the ligamentum flavor. So you are making it more room, because if you see the anatomy, the distance between the ligamentum flavor and the thecal sac in cervical area is hardly 1.5 to 2 mm only. The area of safety margin is very less. So if you are not smart enough to appreciate LOR exactly at the pinpointedly, there is a probability that you may puncture the dura. So that's why when you try to flex the neck by putting a pillow under the chest, not only the interlaminar window is made wide open, but also the thecal sac is pushed away from the ligamentum flavor. So area of safety is increased, so that there is no question of, I don't say no question, the probability of dural puncture is reduced. I hope you understood. Okay. So there comes another question, that sometimes when you take a epi view shadow before starting the procedure, you should be able to appreciate the end plate and upper border of the lamina. Always the end plate is a little higher than the upper border of the lamina, because any procedure in pain intervention, you are supposed to square the end plates. In this case, since you are not squared the end plates, you did not know where you are landing. So you landed somewhere here and you try to slip more. Very acute angle, you have entered into the interlaminar window. That should not happen. You are getting my point? So in order to appreciate the end plate and you want to differentiate between the end plate and upper border of lamina, you got to wig-wag the C-arm little, so that ultimately the end plates are squared. If you look at here in this image, you see this is pedicle. Are you able to appreciate these are pedicles? The whole eye images in fluoro is nothing but pedicle. Okay, everyone. So if you follow the pedicle down, this is lamina and this is a spinous process. Here comes the end plate. Don't get confused with the end plate. So thinking that this is the lamina and you try to go blindly, not under real-time flow, not under fluoroscopy, there is a probability of dural puncture. So your area of interest is here. Sometimes your fluoro is not good and the image is not that clear. You are not able to make out between the end plate and upper border of lamina. What to do? Simple, smart. Just to go adjacent to the spinous process, little upper part of the spinous process. Then there you start your doing the procedure from that point. That's other way of doing it. I hope you understood. All of you. So always make out the difference between the end plate and upper border of lamina. Thank you. For any procedure wherein you are using any needle bigger than 26 gauge needle, you are supposed to give local anesthesia. Even when you are doing spinal anesthesia, with 27 gauge needle, you don't require to give local anesthesia. If you are giving it 28 gauge, local anesthesia is not required. But if you are doing it 25, 23, 22, yes, it is mandatory to give local anesthesia. This is an international guideline. That is anything bigger than 26 gauge. So since here in cervical epidural injection, we are going to use a 18 gauge needle, you are supposed to give local anesthesia. You see this is a bottle, this is a lignocaine, lidocaine. Some trades come as xylocaine. So what I am going to use is, this is a preservative free xylocard, which normally the cardiologists use it. I am not going to use the lignocaine which comes in the market as local anesthetic, which has got a preservative in the form of methylparaben, which can have some amount of allergic reactions, because now the pain interventions are being done world over by some of the orthopedicians, some neurologists, neurosurgeons, anesthetists. Yes, I say the anesthetists are smart enough to resuscitate a patient at any point of time, but this is being done by all other physicians also, so they should learn to give the safest molecules to the patients. So I advocate giving a xylocard. This is normally available in 2%. I am going to dilute it to 1% with saline, so that we are going to give only sensory dose. Why I am going to dilute is, in case if I am going to perform a multi-procedure, multiple levels, I don't want to exceed the toxic dose. That's the area of interest. That's my ideology. Okay. Now I will take this xylocard, which he is holding, is my assistant, Mr. Upender. You see, and if you see here, I am taking almost 2.5 cc of xylocard. I will dilute this with normal saline. Normal saline, where is the, yeah, if you see here, you take This is normal saline. This is a preservative normal saline. Now we are going to insert. What is this? Spike. Yeah. This is mini spike. Open the bottle. This tube should maintain sterility, sterile. Okay, that's it. Now we can open the cap. Okay. It has got a filter. Yeah. So we are going to dilute. So this is the local anesthetic mixture which we are going to give the patient. This is 1% xylocard. I have attached a 26 kg needle, very small needle for local infiltration. Local anesthesia is mandatory. Always make a wheel, then you get inside. Thank you. Now if you see the patient position, patient is in prone, head down, patient is conscious, cervical epidurals are to be done not under conscious sedation or something like. Patient should be conscious under ASA monitoring with a pillow under the chest so that the neck is flexed, patient is conscious. I will tell you some tips in order to avoid much radiation, since we want a C7D1 or D1D2 or as I said you 6 and 7. So when you start counting from the upper cervical area to down, the most prominent vertebrae is your C7 spinous process. When you start counting from here, the most prominent one is C7. When you are counting from caudal to cephalad, the most prominent one is what? D1, and the last prominent is C7. Okay, either way you can count. So I could find it here. So then I am placing little adjacent to that place, so that unnecessarily I don't require to take too many shoots to find out exact area where I want to give. That's number 1 point. Number 2, spill over few needles, 1 or 2 different types, different sizes. Now you see you have put 1 Tohi needle, I'll put 1 more Tohi needle somewhere here, or 1 needle, 1 more here, another needle, 3-4 needles are different sizes, and take 1 single shoot. Then you identify where you wanted to do. So directly you can give a local, otherwise you keep on shooting and you try to move the needle here and there to find out exact target area. So you want to avoid radiation, 1 shoot for identification of your site where you want to do the procedure. Spill multiple needles of different sizes. Okay. Number 3, C-arm should be straight down in AP with 5 degrees inclination towards the area of interest. Now the patient's right side is this side, left is that side. I want to do on the right side. So 5 degrees little. Why 5 degrees little? Can anyone bring the cervical, the bone model? You see the lamina is exactly 45 degrees this side. If I try to take, if you see the lamina like this, yes. You see the lamina is like this. If I take AP shoot, since they are oriented, this area, the overall width size will get reduced if you take AP shoot. If I try to push the C-arm little towards my right side, I can nicely make out the full length of lamina. So I know where I am landing. That is the idea. It is given in one of the texts of pain. Number 1. Number 2, you can wigwag the C-arm little cephalad, little caudal, because there is some amount of cervical lordosis. So ultimately end plates are to be squared. In this case the end plates are already squared, and here when you take a 5 degrees inclination towards the side where you wanted to do, your image, when you see the pedicle to spinous distance of one side will be more, the other side will be less ultimately. Now in this case, if you see the right side, the complete lamina is made out. So the distance between the spinous process to the right pedicle is more when compared to the spinous process to the left pedicle. This is what the image which you should get in a fluoroscopy. And you can do little cephalad tilt. Here we have done 5 degrees cephalad tilt and 5 degrees towards the right. So ultimately this is a final positioning of the fluoro, and always fluoro should be opposite. For example, I am doing right side, the fluoro should be on the left side. This is mandatory. Otherwise you will struggle, because if I keep the fluoro on the right side only, once you want to get a contralateral oblique, the C-arm cannot rotate beyond 30 degrees. You are getting my point? If the C-arm is positioned on the opposite side, you can rotate up to 45, 55, 60, lateral, everything you can get it done. So, okay. Now, take a shoot. Yeah. Now, there in the image, are you able to make out the lamina as well as the end plates? Hope you understand. I will anyhow explain about that image also. We will give local. You see, this is local. 1% preservative free xylocard. I diluted with preservative free normal saline. Now I am going to inject local anesthesia. You see here, that's a marker, one of the marker I am pulling out because it is far away from my target, and this is there. You see here, nicely draped. We applied scrub. After doing scrubbing, then we have draped, applied betadine. Patient is conscious. Pulse oxy attached. I am giving a local. Nana chinna sudi. Okay, we have given local. Okay. Now wait for at least 2 to 3 minutes. Then you load your drugs. Either it is a dye or your so-called normal saline for flushing, and your drug 0.2% roping with a steroid. Coming to the steroid, again I am telling you for newcomers, you got two types of steroids. One is particulate, one is non-particulate. Non-particulate steroids are your dexamethasone. Particulate is your betamethasone, your triamcinolone, your methylprednisolone. Their size is more than the size of RBCs, and whenever you are giving in and around spine, always give only the non-particulate steroid in the form of dexamethasone. Otherwise, whenever you are giving, if it inadvertently gets into the epidural vessels, the smallest of the smallest spinal vessels, it can occlude, it can block, that can lead into anterior spinal syndrome, and there are a lot of documentation on that also. So you should be very cautious about it. Even you are expertise in doing epidurals. I hope you understand. But there is a small exception, since artery of Ādāmquist goes up to L2, sometimes even below that. So any procedure below L2, L3, you can give particulate or non-particulate, there is no much difference. But if you are giving above L2 up to cervical area, dexamethasone, that's why intraoperatively, if you see most of the spine surgeons like me or some other spine surgeons, when they open it, they spill little dexamethasone and come out. You have never seen spilling methylprednisolone over there. Have you seen that? Okay. Now if you see the fluoroanatomy, this is a AP picture, but if you see the distance between the spinous process and the pedicule, so if you see, this is a fluoroanatomy of the cervical spine. So as I said you, if you look at here, this is D1, thoracic number 1, this is D2, this is C7, C6. So how do I know that this is D1? You see the first rib, and this is the transverse process of the D1. It is almost articulating somewhere here. So this is D1, this is C7. The ideal position is the intersection of cervical and thoracic, that is C7 D1 space. It is a better space. I tell you why. This is a one space wherein you can go for cervical epidural, or one space below, that is D1 D2, or one space above, that is what? C6 C7 also. I already told you, because at higher levels the ligamentum flavum is deficient or very thinned out, you cannot make off loss of resistance to saline or air sometimes, which can lead into inordinate dural puncture. So if you look at the fluoroanatomy, these are the pedicles, and this is a long transverse process of D1, and this is a rib. If you see the distance between the spinous process to the pedicle, here it is more, here it is less. The reason is, I told you already, our area of interest is on the patient's right side. So we have inclined the C-arm 5 degrees towards right side so that I can make out the lamina full length. So I know where I am landing. That's number one point. So in all pain procedures, we see that in AP, the spinous to pedicle distance is equidistant. But in cervical, since they are oriented almost at 45 degrees, I want to make out full length of lamina. I have tilted the C-arm. That's why the distance here is more, it is less. That's number one point. Number two, you are supposed to make out, this is a spinous process, this is a lamina, and here comes the end plate. You should be able to appreciate between the end plate, which is placed little higher when compared to the upper border of the lamina. That is very important. And always try to target the upper border of the lamina once you hit. Since bone is your friend in all the pain interventions, hit the bone and slip. That's it. While slipping, you have to do LOR to saline or air, depending upon your area of preference. I hope you understood. This is the picture. Now we are given local infiltration. Now we are going to do epidural. Now if you see, we have inserted the Tohees needle in AP. There are two things, 3Ds, depth, direction, depth. For the sake of direction, you see AP view. For the sake of depth, you can take a lateral or you can take a contralateral oblique. So here, direction is done. Already we are just in the zone 1, adjacent to the spinous process. We know. Now we have taken a contralateral. How to make a contralateral oblique? I told you already. We are doing on the right side, the C-arm should be opposite side. That's number one point. Number two, we have made the C-arm 45 degrees. should complete CM 45 degrees. Since the lamina is like this, I am making this part of the lamina. Now just imagine the lamina is like this. This part of the lamina should be in plane with the X-ray beam. You got the point? Yes. So this is the exact positioning of the CM. Anyhow, I will explain that afterwards. So once we have docked the needle on the upper border of the lamina, once we have hit the bone, bone is our friend. Now we have got to slip. So now you see how I am holding the epidural to his needle wings. Are you able to see? This is loss of resistance to air. This is how you have to go inside till you get LOR. Okay? Till you get LOR. Yeah, once we have got LOR to either saline or air, now this is a IPEC dye aspirated. Then see it's a free flow of dye. This either you can put an extension line and do under real time, or after injecting dye wait for 6 seconds, take a shot. Excellent. After giving high IOPEC dye, after confirming that we are in the epidural space, given normal saline, this is a 0.2% ropivacaine with dexamethasone and a high nidase. This is a chronic and acute case. He has got 2-level disc. Under vigilance by your monitor, see, I am giving the drug because sometimes you may get even to his needle hitting the dura. It can cause some amount of vasovagal also. So you should be cautious. You should listen to the popping sound from your pulse oxy. That's mandatory. Baane unnara? Then ibbandi unda? That's it.